Male factor infertility refers to any condition in the man that impairs the production, function, or delivery of sperm capable of fertilizing an oocyte. This includes quantitative defects, low count or no sperm; qualitative defects, poor motility, abnormal morphology, DNA fragmentation, and obstructive problems that prevent sperm from reaching the ejaculate. In clinical practice, the definition is used to triage couples to appropriate diagnostic work-up and to decide whether treatment should target the male partner, the female partner, or both. For centuries, infertility was assumed to be a woman's problem because most diagnostic tools focused on the female reproductive tract. It was not until the 20th century advent of semen analysis, hormonal assays, and later genetic testing that the contribution of the male partner was quantified, revealing that men are responsible for roughly 40 to 50% of all infertility cases. This shift transformed reproductive medicine, leading to the development of male-focused clinics and research programs. Early identification of male infertility enables timely intervention, reduces the emotional burden on couples, and often improves overall treatment success. For example, a man with a reversible hormonal deficiency can be started on clomiphene citrate, restoring spermatogenesis within months and allowing natural conception. Conversely, recognizing an irreversible azoospermia early directs the couple toward assisted reproductive technologies, such as TESEICSI, avoiding unnecessary cycles of ineffective therapy. Genetic defects are a major cause of non-obstructive azoospermia and severe oligospermia. Klinefelter syndrome leads to testicular dysgenesis, low testosterone, and absent sperm in up to 90% of affected men. Microdeletions on the ZF region of the Y chromosome remove genes essential for spermatogenesis, resulting in variable sperm production loss. Genetic counseling is crucial because these abnormalities are often inherited and have implications for offspring. The hypothalamic pituitary testicular, HPT, axis controls sperm production through gonadotropins, FSH, LH, and testosterone. Hypogonadotropic hypogonadism, low FSH/LH, can be caused by pituitary disease, Kalman syndrome, or excessive stress, leading to low sperm output that often responds to exogenous gonadotropins. Hypergonadotropic states, high FSH, low testosterone, indicate primary testicular failure, commonly seen in Klinefelter syndrome or chemotherapy exposure. Physical abnormalities such as varicoceles, dilated pampiniform plexus veins, congenital absence of the vas deferens, often linked to CFTR mutations, or ejaculatory duct obstruction impede sperm transport. Varicoceles increase scrotal temperature and oxidative stress, reducing count and motility. Surgical ligation improves semen parameters in 60 to 70% of cases. Obstructive lesions may be bypassed with microsurgical reconstruction or sperm retrieval directly from the testis. Exposures that raise scrotal temperature, hot tubs, tight underwear, toxic chemicals, pesticides, phthalates, smoking, excessive alcohol, and obesity generate oxidative stress and endocrine disruption. For instance, men who quit smoking for 3 months show a 20% rise in progressive motility. Weight loss of 10% can increase testosterone levels by up to 30%. Acute orchitis from mumps, chronic prostatitis, or epididymitis can scar the seminiferous epithelium or obstruct the epididymal duct. A classic case is mumps orchitis in adolescent boys, which may result in permanent azoospermia in 13% of cases. Prompt antimicrobial therapy and anti-inflammatory treatment can preserve spermatogenesis when administered early. Chemotherapeutic agents, alkylating agents, cisplatin damage rapidly dividing germ cells, often causing permanent azoospermia. Anabolic steroids suppress the HPT axis, leading to hypogonadism, while some antiepileptics, for example valproate, alter sperm motility. Fertility preservation, sperm banking, before initiating such therapies is now standard of care. Chronic illnesses like diabetes mellitus cause microvascular damage and oxidative stress in the testes, reducing sperm count and increasing DNA fragmentation. Thyroid disorders affect metabolic rate. Hyperthyroidism can increase SHBG, lowering free testosterone, while hypothyroidism may impair Sertoli cell function. Managing these systemic conditions improves reproductive outcomes. Spermatogenesis takes about 74 days and proceeds through mitosis, meiosis, and spermiogenesis. Disruption can occur at any stage: germ cell apoptosis from heat stress, meiotic arrest due to genetic defects, or defective spermiogenesis caused by endocrine imbalance. Clinically, this manifests as oligospermia, pteridozospermia, or complete azoospermia, often confirmed by testicular biopsy. Alterations in the feedback loop between the hypothalamus, pituitary, and testes can produce discordant hormone patterns. Excess estrogen, for example from obesity, suppresses GnRH, leading to low LH/FSH and secondary hypogonadism. Conversely, primary testicular failure yields high gonadotropins due to loss of negative feedback. Hormone replacement or stimulation, HCG, clomiphene, is tailored based on these patterns. Reactive oxygen species, ROS, attack the polyunsaturated fatty acids of the sperm membrane and the tightly packed DNA within the head. Elevated ROS correlates with increased DNA fragmentation index, DFI, which predicts lower fertilization rates and higher miscarriage risk. Antioxidant therapy, vitamin C, CoQ10, can reduce DFI by 10 to 15% in selected patients. Obstructions in the epididymis, vas deferens, or ejaculatory ducts prevent sperm from reaching the semen. Causes include congenital agenesis, post-infectious scarring, or surgical injury. Diagnosis uses transrectal ultrasound and vasography. Treatment options range from microsurgical reconstruction to direct sperm retrieval for IVF and ICSI. Anti-sperm antibodies (SA) develop after trauma, infection, or vasectomy, binding to sperm surface antigens and impairing motility or fertilization. The mixed antiglobulin reaction (MAR) test detects a SA. Immunosuppressive therapy has limited success, so assisted reproduction with ICSI, which bypasses antibody-mediated blockade, is the preferred management. Approximately 15% of couples worldwide experience infertility, and male factors are implicated in about half of these cases. Large epidemiological surveys show a slow but steady increase in the proportion of male-related infertility, likely reflecting lifestyle changes, environmental exposures, and better diagnostic awareness. Sperm concentration declines by roughly 1 to 2% per year after age 35, and DNA fragmentation rises sharply after 40. Men over 50 have a threefold higher risk of transmitting chromosomal abnormalities to offspring. Therefore, age should be considered alongside female age when counseling couples. Studies show higher average sperm concentrations in Scandinavian men compared with East Asian or African populations, likely due to differences in diet, higher omega-3 intake, environmental pollutants, and genetic background. These variations emphasize the need for population-specific reference ranges in semen analysis. Male infertility accounts for 30 to 40% of all diagnosed infertility cases when both partners are evaluated. In mixed-factor couples, the male contribution often determines the choice of treatment, whether to pursue intrauterine insemination, IUI, versus IVF with ICSI. low ejaculate volume less than 1.5 milliliters, may indicate hypogonadism, ejaculatory duct obstruction, or congenital absence of seminal vesicles. Measuring fructose levels in the seminal plasma can differentiate obstructive from hormonal causes. Management may involve surgical correction of the obstruction or hormonal therapy to stimulate accessory gland function. Persistent orchialgia can be a symptom of epididymitis, torsion, or chronic varicocele. A thorough physical exam combined with scrotal Doppler ultrasound helps differentiate vascular from inflammatory causes. Treatable conditions, such as bacterial prostatitis, respond to antibiotics and often improve spermatogenesis. Physical clues like a palpable varicocele, a bag of worms feeling, gynecomastia, or an undescended testis provide immediate insight into underlying etiologies. For example, a unilateral non-palpable vas deferens strongly suggests cystic fibrosis transmembrane conductance regulator, CFTR mutations, prompting genetic testing. Systemic symptoms such as decreased libido, erectile dysfunction, and chronic fatigue often accompany hormonal deficiencies that also affect spermatogenesis. Screening testosterone levels in men presenting with these complaints can uncover hypogonadotropic hypogonadism early. Semen analysis remains the cornerstone diagnostic test. The WHO 2021 reference limits are volume greater than or equal to 1.5 milliliters, concentration greater than or equal to 15 million per milliliter, total motility greater than or equal to 40%, progressive motility greater than or equal to 32%, and normal morphology greater than or equal to 4% strict Kruger. Repeated testing is recommended to account for intra-individual variability. A baseline hormonal panel includes FSH, LH, total and free testosterone, estradiol, prolactin, and thyroid-stimulating hormone TSH. Elevated FSH with low testosterone implies primary testicular failure, while low FSH and LH with low testosterone points to secondary hypogonadism, guiding subsequent therapy. Karyotype analysis detects aneuploidies, for example 47XXY, while Y chromosome microdeletion PCR panels assess a ZFA, a ZFB, and a ZFC regions. Men with a ZFC deletions may still have retrievable sperm via TESE, whereas a ZF deletions usually preclude successful sperm retrieval. Scrotal ultrasound evaluates testicular volume, echoxture, and vascular flow, identifying varicoceles, tumors, or microlithiases. Transrectal ultrasound TRUS visualizes the seminal vesicles and ejaculatory ducts to detect obstructive lesions. When non-invasive tests are inconclusive, a testicular sperm extraction TESC or micro-TESC obtains tissue for histopathology and potential sperm retrieval. Histologic patterns, Sertoli cell only, maturation arrest, hypospermatogenesis predict the likelihood of successful ICSI. Advanced assays include sperm DNA fragmentation testing, TUNEL, SCSA, and antisperm antibody detection, MAR test. Oxidative stress can be measured by chemiluminescence. These tests refine prognosis and help select the most appropriate assisted reproduction technique. Oligospermia is defined as a sperm concentration less than 15 million per milliliter. Azoospermia is the complete absence of sperm. Asthenozoospermia denotes reduced progressive motility, less than 32%. And pteridozoospermia reflects a high proportion of morphologically abnormal sperm, less than 4% normal forms. Each condition requires a tailored workup: hormonal assessment for oligo and azoospermia, oxidative stress evaluation for astheno, and genetic testing for severe teratoe. Obstructive azoospermia, OA, occurs when sperm production is normal, but a physical blockage prevents ejaculation. for example, vas deferens agenesis, post-vasectomy. Non-obstructive azoospermia, NOA, stems from impaired spermatogenesis due to genetic, hormonal, or toxic insults. OA typically allows sperm retrieval via epididymal aspiration, whereas NO often requires micro-TESC. Classifying male infertility by predominant etiology streamlines management. Hormonal subtypes, for example, hypogonadotropic hypogonadism, respond to endocrine therapy. Anatomical subtypes, varicocele, ejaculatory duct obstruction, are treated surgically. Genetic subtypes, Klinefelter, Y microdeletions, may require assisted reproduction and genetic counseling. Weight reduction of 5 to 10% can raise testosterone by 30 to 40% and improve sperm concentration. Smoking cessation leads to a 12 to 15% increase in motility within 3 months. Avoiding tight underwear and hot baths reduces scrotal temperature, which has been shown to improve count by up to 20%. Pharmacologic options include clomiphene citrate, selective estrogen receptor modulator, to increase endogenous LH/FSH, aromatase inhibitors, anastrozole, to lower estradiol, and antioxidant supplements, vitamin E, coenzyme Q10, to mitigate ROS. Treatment duration typically spans 3 to 6 months, with semen analysis repeated to gauge response. Microsurgical varicocelectomy via a subinguinal approach yields the highest pregnancy rates, up to 40% within a year. For obstructive causes, vaso-epididymal anastomosis restores patency. Testicular sperm extraction, TESE, provides sperm for ICSI when sperm are absent in the ejaculate. IUI can be effective when total motile sperm count exceeds 5 million post-wash. IVF with conventional insemination requires greater than 10 million motile sperm. When sperm numbers are low or motility impaired, ICSI intracytoplasmic sperm injection directly injects a single sperm into each oocyte, achieving live birth rates of 60 to 80% with TESE-derived sperm. Experimental approaches include CRISPR-based gene editing to correct monogenic defects in spermatogonial stem cells, and stem cell-derived sperm from induced pluripotent cells. While promising, ethical, safety, and regulatory hurdles remain before clinical translation. Occupational health measures that limit exposure to heat, heavy metals, and radiation protect the germ line. For example, providing cooling vests for steelworkers reduces scrotal temperature by 1 to 2 degrees Celsius, correlating with a modest rise in sperm concentration. Early screening of adolescent males, such as a single serum FSH measurement combined with a brief reproductive health questionnaire, can uncover subclinical hypogonadism, allowing timely hormonal therapy before irreversible testicular damage occurs. National campaigns that integrate male reproductive health into general wellness messages increase awareness. In Sweden, a 5-year public health program led to a 12% rise in men seeking fertility evaluation before age 35. Key predictors include male age. Younger men have higher sperm DNA integrity. Etiology: obstructive azoospermia has better IVF outcomes than non-obstructive. Treatment type: ICSI with TESE sperm yields higher live birth rates than IUI for severe oligospermia. Lifestyle modification alone achieves pregnancy in 10 to 20% of couples with mild oligospermia. Hormonal therapy can raise success to 30 to 35%. Surgical varicocelectomy adds another 10 to 15% incremental benefit. ICSI with testicular sperm retrieval boasts a live birth rate of 60 to 70% per cycle in NOA patients. Men with untreated infertility have a 1.5 to 2-fold increased risk of testicular cancer. and epidemiologic data link low sperm parameters to cardiovascular disease. Long-term follow-up with metabolic screening is therefore recommended. Beyond count and motility, biomarkers such as mitochondrial membrane potential, intracellular reactive oxygen species levels, and DN, a fragmentation index, provide a more nuanced view of fertilizing potential. High mitochondrial activity correlates with better embryo quality after ICSI. Preclinical studies have used CRISPR to correct point mutations in the SYCP3 gene of mouse spermatogonia, restoring normal spermatogenesis. Translational research is focusing on ex vivo editing of human spermatogonial stem cells followed by autologous transplantation, though ethical considerations are paramount. Microfluidic devices exploit rheotactic and chemotactic cues to isolate motile, morphologically normal sperm without centrifugation, reducing DNA fragmentation. Clinical trials show a 12% increase in blastocyst formation rates when microfluidic selected sperm are used for ICSI. Metagenomic sequencing of semen samples reveals that a high relative abundance of lactobacillus species is associated with better motility, whereas overgrowth of ureaplasma correlates with elevated reactive oxygen species. Probiotic supplementation is being investigated as an adjunct therapy to improve semen quality. Large-scale analyses, such as the European Male Infertility Cohort EMIC, have documented a 50 to 60% decline in median sperm concentration from 1970 to 2020, independent of age, suggesting environmental and lifestyle factors as major drivers. Research on reversible hormonal male contraceptives, for example 11-beta-MNT, includes a reversal agent that rapidly restores gonadotropin secretion.